ECG for MBBS students. This lecture covers the basics for MBBS students. Welcome back, students. In this video, we will cover use of electrocardiogram or ECG as an investigational tool to diagnose cardiovascular disease. I suggest that you should pause and replay the segment in the video that you are unable to understand in the first go. If you still have difficulties understanding the concept, you can add it to the comments below the video. Let's begin. The ECG is used to assess heart rhythm and conduction. It provides information about heart chamber size. We are interested mainly in left ventricle, which is the main pump affecting blood pressure and circulation, but sizes of right ventricle and both atria are also important and can be estimated by looking at ECG. You should know that atrial chamber enlargement is a precursor for atrial fibrillation. In such patients, atrial fibrillation is difficult to revert to sinus rhythm, and we have to settle for rate control in preference over rhythm control. ECG is the main test used to assess for myocardial ischemia and infarction. How does the ECG work? The basis of an ECG recording is that the electrical depolarization of heart muscle produces a small current which can be detected by electrodes placed on the body surface. To produce a readable ECG, these signals are amplified. Amplified signals can then be either printed or displayed on a monitor. During sinus rhythm, the SA node triggers atrial depolarization, producing a P wave. In my previous video on anatomy and physiology of cardiovascular system, I told you that there is a cushion or electrical barrier between atria and ventricles. The only way for the depolarization wave to pass from atria to the ventricles is through the AV node. The slow conduction property of AV node is what causes atria to contract before the ventricles and allows time for the ventricles to fill before next ejection cycle. Once the depolarization wave crosses AV node, the bundle of his bundle branches and Purkinje system are then activated, initiating ventricular myocardial depolarization. The wave of depolarization of ventricles can be recorded in the ECG in the form of QRS complexes. The part of the heart that has maximum muscle will produce highest voltage on ECG. We all know from our previous knowledge that the muscle mass of the left ventricle is much larger than that of the atria and even the right ventricle, so the QRS complex is much larger than the P wave. The interval between the onset of the P wave and the onset of the QRS complex is termed the PR interval, and largely reflects the duration of AV nodal conduction. Injury to the left or right bundle branch delays ventricular depolarization, widening the QRS complex. Repolarization is a slower process that spreads from the epicardium to the endocardium. Atrial repolarization does not cause a detectable signal, but ventricular repolarization produces the T wave. The QT interval represents the total duration of ventricular depolarization and repolarization. The standard 12-lead ECG. The 12-lead ECG is generated from 10 physical electrodes that are attached to the skin. One electrode is attached to each limb and 6 electrodes are attached to the chest. In addition, the left arm, right arm and left leg electrodes are attached to a central terminal acting as an additional virtual electrode in the center of the chest. The right leg electrode acts as an earthing electrode. The 12 leads of the ECG refer to recordings made of the potential difference between any two of these electrodes. Leads are divided into 3 groups. 3 limb leads, 3 augmented limb leads, and 6 unipolar chest leads. The limb leads and augmented limb leads record ECG in the frontal plane and are called frontal leads. Leads 1, 2 and 3 are the dipole limb leads and refer to recordings obtained from pairs of electrodes placed on different limbs. Lead 1 records the signal between the right and left arms. Lead 2 records the signal between the right arm and left leg. Lead 3 records the signal between the left arm and left leg. These 3 leads thus record electrical activity along 3 different axes in the frontal plane. Leads AVR, AVL and AVF are the augmented voltage limb leads. These record electrical activity between a limb electrode and a modified central terminal. For example, lead AVL records the signal between the left arm and a central terminal formed by connecting the right arm and left leg electrodes. Similarly, augmented signals are obtained from the right arm AVR and left leg AVF. These leads also record electrical activity in the frontal plane, with each lead 120 degrees apart. Lead AVF thus examines activity along the axis plus 90 degrees, and lead AVL along the axis minus 30 degrees etc. When depolarization wave moves towards a positive electrode, it produces a positive deflection in the ECG. On the other hand, when depolarization wave moves away from the electrode, it produces a negative deflection. This is the reason why we have different shape of QRS in different leads, because they are recording ECG from their own reference point. In layman terms, we have 12 people looking at the same depolarization and repolarization phenomenon from 12 different angles and therefore 12 different shapes for ECG in each lead. What is meant by the frontal cardiac axis of depolarization, or in simpler terms axis? Axis is the average of all the ventricular depolarization vectors recorded by the frontal leads, that is lead 1, 2, 3, AVL, AVR, and AVF. When the depolarization vector is at right angles to a particular lead, the ECG record in that lead is equally negative and positive and is also called isoelectric. In this example, the QRS complex is isoelectric in AVL, negative in AVR and most strongly positive in lead 2. The axis lies near the positive end of the lead, having maximum positive voltage. In this example, the main vector or axis of depolarization is therefore plus 60 degrees. If the average frontal cardiac axis vector lies between minus 30 degrees and plus 90 degrees, we presume it to be a normal axis. The cardiac axis may vary between normal individuals from minus 30 degrees and plus 90 degrees depending upon their posture, electrode placement, shape and size of their chest, deformities of ribs and spine etc. If the axis lies beyond the normal range, we need to look for causes of abnormal conduction or abnormalities in heart chamber sizes. Chest leads. There are 6 chest leads, V1 V6, derived from electrodes placed on the anterior and lateral left side of the chest, over the heart. Each lead records the signal between the corresponding chest electrode and the central terminal. Leads V1 and V2 lie approximately over the right ventricle. Leads V3 and V4 lie over the interventricular septum. And leads V5 and V6 over the left ventricle. We have already discussed that the left ventricle has the greater muscle mass and contributes the major component of the QRS complex. Depolarization of the interventricular septum occurs first and the wave moves from the left to right side of the septum. This generates a small initial negative deflection due to a way movement of depolarization wave in lead V6 that measures voltage from axilla. The same wave produces an initial positive deflection in lead V1 due to wave moving towards the right ventricle over which V1 is placed. The second phase of depolarization is activation of the left ventricle, which creates a large positive deflection or R wave in V6, wave moving towards V6 in axilla, and reciprocal changes, negative deflection or S wave in V1. The third and final phase involves the right ventricle depolarization and produces a small negative deflection or S wave in V6. Now we will see how to read a 12-lead ECG. Conventional ECG readings. Depolarization towards electrode produces positive deflection. Depolarization away from electrode produces negative deflection. Sensitivity of ECG. 10 mm is equal to 1 millivolts. Paper speed is 25 mm per second. Each large 5 mm square is equal to 0.2 seconds. Each small 1 mm square is equal to 0.04 seconds. Heart rate is equal to 1500 divided by the RR interval, INM, or 300 divided by number of large squares between beats. Rhythm strip. To determine heart rate and rhythm we most commonly use lead 2. But why lead 2? Reason is because its axis lies within the normal range and P waves are largest in this lead. P wave shape. Tall P waves denote right atrial enlargement, P pulmonale, and notched P waves denote left atrial enlargement called P mitral. PR interval. Normal interval is 0.12 to 0.20 seconds. Prolongation denotes impaired AV nodal conduction. A short PR interval occurs in Wolff-Parkinson-White syndrome. QRS duration. If more than 0.12 seconds, then ventricular conduction is abnormal, left or right bundle branch block. QRS amplitude. Large QRS complexes occur in slim young patients and in patients with left ventricular hypertrophy. Q waves may signify previous myocardial infarction MI. ST segment. ST elevation may signify MI, pericarditis or left ventricular aneurysm. ST depression may signify myocardial ischemia or infarction. T waves. T-wave inversion has many causes, including myocardial ischemia or infarction, and electrolyte disturbances. QT interval. Normal less than 0.42 seconds. QT prolongation may occur with congenital long QT syndrome, low potassium, magnesium or calcium, and some drugs. The ECG in ischemia and infarction. When an area of the myocardium is ischemic or undergoing infarction, repolarization and depolarization become abnormal in that particular area. In transmural infarction, there is initial ST segment elevation, the current of injury, in the leads facing or overlying the infarct. Q waves or negative deflections will then appear as the entire thickness of the myocardial wall becomes electrically neutral relative to the adjacent myocardium. The infracted zone behaves like a neutral window through which opposite wall is visible. The electrode overlying the infracted zone picks depolarization waves on the opposite wall of the left ventricle. The waves in the opposite wall will always be seen moving from the endocardium towards the epicardium. This away movement is picked as Q waves in the electrodes overlying infracted zone. In myocardial ischemia, the ECG typically shows ST segment depression and/or T-wave inversion. It is usually the subendocardium that most readily becomes ischemic. Other conditions, such as left ventricular hypertrophy and electrolyte disturbances, can cause similar ST and T-wave changes. Exercise or stress ECG. Exercise electrocardiography is used to detect myocardial ischemia during physical stress and is helpful in the diagnosis of coronary artery disease. A 12-lead ECG is recorded during exercise on a treadmill or bicycle ergometer. The limb electrodes are placed on the shoulders and hips rather than the wrists and ankles. The Bruce protocol is the most commonly used protocol for treadmill testing. BP is recorded and symptoms assessed throughout the test. Common indications for exercise testing are the following. To confirm the diagnosis of angina. To evaluate stable angina. To assess prognosis following MI. To assess outcome after coronary revascularization, like coronary angioplasty. To diagnose and evaluate the treatment of exercise-induced arrhythmias. High-risk findings on stress test are: low threshold for ischemia that is within stage 1 or 2 of the Bruce protocol. Fall in BP on exercise. Widespread, marked or prolonged ischemic ECG changes. Exercise-induced arrhythmia. False negative results can occur in patients with coronary artery disease, and some patients with a positive test will not have coronary disease, called false positive. Exercise testing is an unreliable population screening tool because in low-risk individuals, asymptomatic young or middle-aged women, an abnormal stress test is more likely to represent a false positive than a true positive test. Stress testing is contraindicated in presence of acute coronary syndrome, decompensated heart failure, and severe hypertension. Ambulatory ECG. Continuous ambulatory ECG recordings can be obtained using a portable digital recorder. These devices usually provide limb lead CG recordings only, and can record for between 1 and 7 days. Ambulatory ECG recording is mainly used in the investigation of patients with suspected arrhythmia, such as those with intermittent palpitation, dizziness or syncope. For these patients, a 12-lead CG provides only a snapshot of the cardiac rhythm and is unlikely to detect an intermittent arrhythmia, so a longer period of recording is useful. These devices can also be used to assess rate control in patients with atrial fibrillation, and are sometimes used to detect transient myocardial ischemia using ST segment analysis. For patients with more infrequent symptoms, small patient-activated ECG recorders can be issued for several weeks until a symptom episode occurs. The patient places the device in the chest to record the rhythm during the episode. With some devices, the recording can be transmitted to the hospital via telephone. Implantable, loop recorders, or small devices that resemble a leadless pacemaker and are implanted subcutaneously. They have a lifespan of 1 to 3 years and are used to investigate patients with infrequent but potentially serious symptoms, such as syncope. That brings us to the end of this lecture on the basics of ECG for MBBS students. Hope you enjoyed the video. For more videos like this, do not forget to like and subscribe the channel. Do post your comments and queries related to the topic. Also, suggestions are invited for the improvement of videos in future.